I would like to introduce Dr. Lawrence. Thank you so much for being with us. Dr. Lawrence is a pediatric ophthalmologist who specializes in early intervention, pediatric low vision, and multiple disabilities. She has a solo ophthalmology practice in Salina, Kansas, and is a consultant for Kansas State School for the Blind. Dr. Lawrence, we are ecstatic you are with us today. The floor is all yours.
Oh, thank you so much. Are the slides up okay?
You look great.
Okay, and you see my slides?
We sure do. Take it away.
Perfect. There's always, even though we do these Zooms all the time, there's always that little bit of, is everything okay? And so I'm just really thrilled to be here. I've been working with Perkins School for the Blind off and on for many years, and have visited several times and had the opportunity to work with Barry Cran and the great team. And I've always learned so much from all of my visits there. And it's funny, I just last week gave a talk on Laura Bridgman and Helen Keller and the relationship of these two amazing women who were both served through Perkins and their connection with Charles Dickens, the famous author. So that's another story, but it just brought me even closer back to Perkins and the wonderful history and how things have evolved now to, really helping us face this, what I would say, a crisis. And in CVI, we're all trying to learn how to serve our kids and our families. So, and as an ophthalmologist, of course, my approach is going to be a little bit different than somebody who's coming from as a parent or as a professional, because like a speech path or a teacher, that's why we need a team, because we all have our unique ways of approaching this. So what I want to show you today is really my clinical approach to evaluating children. And I think a part of me is because I want to empower all of you to go back to your ophthalmologist and say, well, Dr. Lawrence says you can assess vision. Well, Dr. Lawrence says you can assess this in babies. And, because I'm trying to put my own pressure on my profession, and it is working to better assess babies and actually the visual function of babies. So that's kind of what my talk is about today. And I just want to acknowledge at the bottom of my slide, all of these people who are my friends, colleagues, and mentors, especially Dr. Leah, who's a lot of her testing and assessment tools I use and I'll be showing, but also my friends in the United States and Dr. Dutton, Daniela Ritchie, who's an amazing pediatric neurologist in Rome, and you should really read some of her stuff on the earliest assessment of babies. Erevin Eye Hospital is doing some amazing work in spreading the interventions and assessments across India and the developing world. And in Brazil, I worked extensively with the Altino Ventura Foundation for about 3 years, where we examined and tried right away when the Zika epidemic started. We knew that those babies were going to have CVI, and we started immediately with this foundation advocating for these children and these families, because we knew, because of the way this virus affected the brain, that these children would have CVI. So some of the pictures that I'm showing today are from Brazil. The parents have all given their permission. So any child's picture is with parental permission. So this is really one of my favorite pictures about the circle of life. And I think it's mainly for us to all remember that a child is different than an adult. And a little child in the walker, he's trying to develop concepts. He's trying to develop functions based on vision, all of his sensories, for example. But if he doesn't have vision, this is going to greatly affect how he learns concepts, versus the older woman who already has a visual memory. So she may have lost her vision, but she has that concept development already. And I think the development of concepts is so important as we look at children with low vision or visual impairment. This was really brought home to me recently when I'm now a grandmother, and my grandson got my mother's walker and walked around with it. And it was just kind of that circle of life thing that, wow, we're needing the same things as we get older as we did when we were younger. So And part of, the parents and the teachers, part of what you need to emphasize to your team and to your ophthalmologist or optometrist is what is the importance of vision? So we have vision. Well, we all take that for granted, but it's not innate for us to understand how important vision is and how maximizing vision is. So these are some good talking points, like vision promotes early motivation to move. The child wants to reach out of their world. They want to go out. They want to experience the world. And as we know, there's a whole set of developmental checklists, and we don't need to go through all of that. But just to give you some talking points, I want my child to be motivated to move. How can we, okay, maybe his world right now is at 30 centimeters where mom's face is, but I want him to go to a foot, and then I want him to go to 2 feet, and then I want across the room. And how can us, through refractive change, addressing refraction like glasses or ocular motility, how can we help that child move out into the world that's going to encourage him to move? We also know that vision provides the experience for concept development and cognition. Again, a child with low vision or poor vision may have empty language or egocentric language because he doesn't know what's out there. So how are we going to, with our interventions, help that child understand what's outside of his body? And of course, we know that vision is important for social emotional development. And another kind of caveat that I learned from my TVIs, teachers I've worked with for many years, is that the parents are the main teachers of the child. Your medical professional doesn't always understand that. We're used to an environment where we order PT, where we order OT, where we order interventions. We're not used to understanding that we don't order school interventions. We don't order parental interventions. That's not something we can write on a prescription. We have to understand and support the parents and the intervention team. So, visual impairment, the impact of visual impairment starts at birth. And this is a little baby from Recife, Brazil, who was born with the congenital Zika syndrome. So he has microcephaly and a variety of neurological complications and poor vision and CVI. And the mothers there were so amazing. They right away got together, a parent group was formed to help support each other. And of course, every child, like every child with CVI or low vision, is absolutely unique and different. So the approach can't be like, we always do this or we always do that, right? But the parents got together and the moms made these slings so they could be close to their chest, they could feel the vibrations of their heart, they could have that intimate one-on-one contact. So this is one of the important interventions that I tell my parents when they have a child with low vision or CVI, how important that is to have that, even though the child may not see your eyes, to have them close to you, to feel your body, feel your warmth, smell you, feel the vibrations in your voice. The other big thing to understand is that vision or visual function and functional vision are different. And again, this is not common language in an ophthalmologist's office. So sometimes you might have to ask, well, we know you said this is a vision. Do you think the vision is functional at that level? Or do you think we know what the acuity is, but my child functions better than that? So the actual measurement of the eyeball functions versus the way the child uses the vision is absolutely can be different. And I think this one study is so important, the ET-ROP study. So this was a huge study looking at children with retinopathy of prematurity. And, of course, our main thing is get the retina attached, right? Keep the retina attached, get that retina good. Well, in the study, over 14% of the children who had good structural retinal outcome, right? The ROP didn't cause a detachment, didn't lead to low vision and blindness, but they still had poor functional vision outcome. So those more than likely were the kids with CVI, although now when we're looking at the actually the anatomy through this newer technique we have called OCT, where we can actually look at the layers of the retina, we're seeing where the fovea, the part of the retina where you get your 20/20 vision, is not formed, or what we call hypoplastic in children with regressed ROP. Now that part of the eye actually directly synapses or connects into the brain. So what we don't know is that an effect from ROP or is an effect from the brain injury or damage in a premature infant. So there's a lot of things we don't know, but so important that just because we have a retina that's attached doesn't mean the child's going to have a good functional outcome. This is one of my favorite little posters. It was developed at Erevin Eye Hospital in Madurai, which is actually the largest eye hospital complex in the world. And we've actually set up an early intervention program that they're expanding in India. And this was done with assistance of USAID. And, you know, our thought was, well, how do we get these babies to the right resources, right? If a mom has a baby and she's like, well, I don't think my child can see, what are the steps you go through? Even in our country, sometimes parents don't know, do I go to the ophthalmologist? Do I go to my optometrist? You know, a lot of parents don't know about early intervention services. If they've never had a child who's needed services, they don't know that there's this amazing, you know, Part C program out there that's free to them if they just get access to it. So for example, in India, where they have none of that, we developed posters that actually showed the parent what the child should be at a certain age. And these posters went into bus stations, marketplaces, you know, wherever the parent, the grandparent, the child care provider would be, so that they had an understanding of what normal, typical childhood development is like for vision, so that they would know when it's appropriate to seek out a professional. You know, so often we hear, well, they're going to grow out of it. Oh, let's wait and see. Oh, you know, a lot of kids are like that. Oh, and that is not the right attitude. And I'm really adamant about, you know, if you think there's something wrong, go seek an assessment. Because if a baby has a poor visual response, it could be any of these reasons and more. This is a child with cerebral palsy, actually in Peru. And he was a child who, you know, they thought he was blind and couldn't do anything. Well, he could do a lot of things. And his problem was when he looked, he couldn't look and reach at the same time. So we demonstrated to the mom and to the teacher that, yeah, he could do these tasks, but the difficulty was looking and doing the task at the same time. So we needed to make some modifications. But a baby with a poor visual response could have an ocular condition. They could have an eye cancer, retinoblastoma, that could be life-threatening. They could have CVI, cerebral or cortical visual impairment. They could have some sort of a severe cognitive or intellectual disability that's not yet been diagnosed. They could have cerebral palsy and just not be able to show us what they can see, maybe because of their motor condition. They could have autism spectrum disorder. And then we have other kids that we have no explanation for a poor visual response. Often these kids are called, or it's said that they have DVM, or delayed visual maturation. Now, and that they'll probably catch up by 6 months. Again, I am not in that camp. I'm very aggressive early with assessing babies and trying to see what we can do for intervention. DVM, or delayed visual maturation, is a retrospective diagnosis. You don't know if it was just a delay until they catch up. So you can't make that diagnosis if they're not caught up. So, and we've had this discussion a lot with Dr. Dunton and some other colleagues about DVM, and there's a lot of disagreement on this, but this is not a very good term. I'm sorry. We have to say that this is not typical visual response, and look for that reason, assess it, and do the proper interventions. So as far as visual developmental milestones, there is some information out there. We went ahead and actually tried to validate a vision assessment battery. And we did that in Brazil at the time of the Zika epidemic. So in this article, and you guys are welcome to look at any of these, but we looked at healthy controls in Brazil that were born at the same time as the children with congenital Zika syndrome. So we could really see, okay, I surveyed, I got Dr. Leah, Deborah Chen, Dr. Dutton, our colleagues in Brazil. We all get together and try to say, what should we measure in these babies? We don't even know what we should measure. And so we designed this developmental checklist, and you can see in the control group over here that, 100% at, for example, for eye contact at 8 weeks, 100% had that. In our group, it was much lower. And if you go down to the 3-month, the 5 to 6 months, 7 to 10 months, and 11 months, we were able to show that a typical child should be able to do these, and our kids were not typical. So let's just talk a little bit about how an ophthalmologist or an optometrist can assess a function of the child. And this is in Brazil. These are our tools. You can see the pediatric fellow and I have, clothes on that aren't too distracting, because one of the things when we're doing testing, and a lot of this most of you guys already know, but is to decrease clutter so that the child can actually look at the object and not be distracted by the clothing. Or so this is my typical toolbox. It has a mirror, some grading paddles, contrast, a few toys, and a fixation paddle. And we're sitting at pediatric ophthalmology right now in Haiti, and we just set this exact kit down to the 2 developing pediatric ophthalmologists, so they can start right now as they're setting up their fellowship program to do the right testing for the child, not just looking at can they fix and follow, but really trying to assess the function. The mirror test this is just a great test, and this is the article here that validates it. But using a simple mirror and having the child look at themselves in the mirror gives you an idea of their function and what distance. For example, if a child can look at themselves in the mirror at, say, 1 foot and make eye contact, and they're seeing themselves, then more than likely you double the distance. So at 2 feet, they may be able to see your face or a child's face or an object. Now, when we're looking at children, it's a snapshot. The time we look at that child is a snapshot. So what I tell my parents is, I'm getting clues about your child. I'm getting a snapshot, so we have a starting point. None of what we see absolutely defines this child. The child might be tired. The child might be having a bad day. I might be having a bad day. Mom might be having a good day or a bad day. So all of that enters into it too. So this is a snapshot. It's a clue to how the child might function. So I always try and tell my parents and teachers, nothing is exact. Nothing defines this child. There may be times when they do way better than what I'm seeing, or there may be times that I may have just got a good day and they may be show me a lot, and at home they don't do this. So it's a snapshot. So this is a snapshot of this little girl at this moment that she could see herself. In this case, it was 3 feet. So we had a good feeling. We could tell her parents, probably at about 6 feet, she's going to be able to see you. So it gives us clues. It gives us a starting point. Okay, visual attention is very closely tied to cognitive development. And I want to show you this little boy. This is another thing I use, a fixation paddle. It has a face on it, and it gives me an idea if they understand the complexity of a face. And if you see this little boy, he looks at the face, that's really good. And then you can you see his head jerking, his head movement? That's oculomotor apraxia. He's not able to move his eyes to follow the fixation paddle. Now, if I moved it really fast, I'd probably say, oh, well, he can't follow. But I didn't. I moved it really slow, gave him plenty of time, and he could follow that, and he could see it. So that child at that instant went from, oh, well, he probably can't see it, to, yeah, he does see it if I give him enough time to look. So kids with CVI, with oculomotor problems, with low vision, need more time. So he's my little movie star here. Let's see. So the other thing I like to use is two little test objects, and this is just an example, and look at shift of gaze. Can that child look from one object to another object? So we have the pursuits. Now we're looking at shift of gaze. If they don't have good shift of gaze and you're showing them 10 toys, they're not going to be able to move from one toy to the other, or from one person to the other person. So the shift of gaze is a really important test, and it's easy to do. And here's our little guy again. He's having, you can see, a lot of difficulty moving from object to object. And let's contrast with this girl, let me move my things, who also is having difficulty, but you see, with giving her a lot of time, did you see she's going from object to object? So she has a slow shift of gaze, and certainly it's not typical, but she is able to do that task. So that's a good thing, but see how important time is. Let's see here, I need to move my people. The other thing I use for every child, whether they have visual impairment or not visual impairment, is I try and get a baseline on their preferential looking. We can do this, these paddles, there's different kinds, but these are the Leia paddles. They're not calibrated to actual acuity, but the chart here shows what's normal for age. So what you do is you plot the measurement you get by showing the paddles against the child's age and look to see if they fit in this typical or normal curve, okay? But you can't say from the Leia gradings, are they 20/20 or 20/30 or 20/40? All you can say is that they're in the normal for age. So let's just demonstrate that. Here's our little guy again. And you can see I have over here, the stripes are large and further apart. And usually the paddle on the right is gray. And so you put the stripe paddle behind the gray paddle and move it out, and you look for the child to look towards it. It's called preferential looking. And again, he's having, he can kind of see that one that I'm showing over on the left, but it's very difficult. And sometimes it's a very quick glance, and this is just the smaller, thinner lines, and he has like no attention to those. So so I would probably record 0.25 CPCM at 30 centimeters, and that would be what I measure as far as his it's not acuity, it's preferential looking. We can also do this with teller acuity cards. The teller acuity cards do have a calibration that tells you an acuity, but there are people who would disagree that it's really an acuity. Anyway, long story, but teller cards are also very good. There's pros and cons. You know, they're heavy, they're expensive, they're hard to find, they're hard to carry around. I personally don't use them for those reasons, but a lot of people do, and it's another good way to get a baseline. What or how small can that child see? Another test we use commonly for contrast is this Heidi contrast test, and it's again a human face. Dr. Leia has said that the 5% is approximately the contrast of a human face. So that's important one to get to, is that 5%. And this is Dr. Leia. I love this picture because she's retired now, and I just love this picture of her, you know, after development of some of these tests. Now here's our little guy again, okay? And we can see what he does with the contrast, and he's not, this one that I'm showing now from the behind is actually the control. You start with the control. If they can't do the control, which has got the highest contrast, you really don't go down into the other ones because they're not going to be able to get it. So all of these tests actually have a control test. So that's a contrast. Now, the way I use this clinically is if I can get the child to see the 5%, I'm thrilled. And then I move back from the child, because remember, the 5% is approximately the contrast of a human face. So if I keep moving back, if I start at a foot, I can say to the parent, wow, if you're a foot from your child, they probably can see the contrast in your face. Move back 2 feet. Do they still see that 5%? Move back 6 feet. So I use it clinically, like in this video. This is kind of a cluttered office. This is not my normal testing site, but we were just trying to demonstrate. And I'm going a little fast, I can tell you. But you can see the little boy. He also has congenital Zika syndrome, and he's bingo. He's looking at that face each time and also reacting to it. He's nonverbal at this point, but you can obviously see by his body language that he's seeing it. And it was so thrilling because I could say, hey, I'm 6 feet back from your child, and he still can differentiate this card. So it's a good sign that he's probably going to be able to see you across the room. So I try and use all of these tests in the clinical situation to directly give information to the parent and also the teachers who work with me. The other thing to remember, and we saw this again and again with kids with CVI, both in Brazil and in India, is especially kids who have had PVL or paraventricular leukomalacia, always check that upper field. We've had kids who just appeared like they had no intact vision at all, and we go to the superior visual field and we find vision there. So we have something to use. And you can see that down here on the lower slide. This is a little boy in India. Again, they thought he was totally blind, had no vision at all. And this is my iPad I put up into superior field with, I have a little xylophone that has some colors, and he tracked and followed side to side. And it was just so amazing and happy for us and the family that he had some intact vision. And this is another little girl with congenital Zika, who again, same thing, they thought totally blind, can't see anything. And we put the object up here in her superior field. Can you see her little eyes moving and following it? And she starts smiling, and it was just really neat. Now, how do you use that information? Well, it's just like when you're feeding the baby, you can start by putting objects in the better, where do they see the best? Let's get some success. It's not all about, well, make them look this way, make them look this way. Where do they get success? Let's put it where they can see it and bring it in and combine with some simple words. So food, and the baby doesn't just have something put in their mouth continuously and they have no idea where it's coming from or what it means. So you want to try and put things in the seeing field to start with. We use the Leia puzzle a lot, and I just love this puzzle. Every child in my office does this, whether they have typical vision or not, because it gives us clues. Not only it helps us train them to do the visual acuity test, but it also helps me understand if they have concrete to abstract thinking. I use this a lot with my children who have autism spectrum, or who are nonverbal, because what we want to know is, do they have abstract concepts and thinking that we can then apply that to our communication devices. So we start this at about 14 months. We start practicing with the kids, and a lot of kids at 18 months to 24 months can actually do an acuity chart. So they're not too young to check acuity. It just takes a lot of time. So we start here. Here's the color side in the upper left, and the color gives a clue. Now you have to remember that about 8% of boys have color vision deficiencies. So the color may not always be a clue, but for most children, the color is a clue. So they might be able to match the object because of the color. You can also look at the way they place the objects. The circle is the simplest shape for the child to understand. It doesn't have direction. The square is the next easiest. When you go to this house and to the apple or heart, or somebody recently told me it was a tooth, it doesn't matter what they call it as long as they're consistent with the name, those have direction and they're a little more complex. So sometimes I'll actually cover the two complex symbols and just see if the child can match the circle and the square. So you kind of learn with doing these tests how to best assess the child. And then we move to the black and white side, which takes away the color clue. And then we move to the two-dimensional. Now what we're doing is we're going from very concrete object into an abstract symbol. This circle is not the same as this orange puzzle piece. It's a representation of it. So the puzzle is the concrete, the flat 2D is the symbolic. Once the child gets those symbols and can match those symbols, whether they do it with a head nod, whether they do it with a touch, however they can match them, then we can go to an eye chart and actually check acuity. And sorry, this is kind of small, but this is a near vision chart down here. And the child just, they can point to it, they can match with a puzzle piece. You have to be creative, and this is a little boy with congenital Zika, severe cerebral palsy. You can see he's got a lot of motor involvement. And watch this. He did it. So never think a child can't do something. So how early is early in trying to do these type of assessments? Well, I used to say at birth or shortly after to my friend Daniela Ritchie said, oh, no, it's way earlier than that. And she has all of these tests validated and documented. And they were doing a big study in Italy before the onset of the pandemic of coronavirus. They had to shut down a lot of the research, of course, everywhere, but they were getting ready to do 11 centers in Italy. So she was able to use a similar thing with grading acuities and showed that fixing and tracking is already present in preterm babies at 30 to 32 weeks of gestational age. So she was going into the NICU with these tools and looking at the babies and validating that, yes, we can check babies very early as far as what their visual functions are. And this is just another paper she's written, and these are kind of small, but down here you can see two of the other objects she uses, which are human faces, and then the grading acuities. Really great work. If anyone wants those references, I have them, and I'm happy to, there's about 8 papers on it. They're wonderful. So now we get to my favorite part. And I know those of you who have heard me speak before know how passionate I am about having every child get proper refraction. And, you know, we need to start in infancy doing good refractions. Sometimes we say, wait and see, but a lot of times, especially if the child's severely delayed, we're going to use glasses, at least to try glasses, to see if correcting the optical error will improve their function. I want to make just mention briefly Photoscreeners, because a lot of the birth to 3 programs now are using Photoscreeners because vision function is supposed to be assessed. And I would like to tell you that these are not reliable in under 1 year, nor are they indicated for under 1 year of age. Even in the 1 to 3 years of age, the machine is faked out so many times because the baby is accommodating, and you'll get these minus prescriptions and a lot of astigmatism, or they'll miss the severely farsighted kids because that child's accommodating at that point. I use a Photoscreener regularly in my office. I use it before and after cycloplegia, whereas when we put the eye drops in, and the eye drops paralyze the baby's ability to change the accommodation so I can get the true prescription. And then I use the Photoscreener as a guide. But remember, these were developed to screen for amblyogenic factors. That means an eye's turning, or there's a big difference between the two eyes. They were not developed as a way to check acuity or refractions, and glasses prescriptions should not be written from these. So if you're using a Photoscreener in a birth to 3 program, it's a good tool, but nothing's 100%. You still need to look at that child's function. So what is a significant refractive error? I know many of you have taken your children or your students, your kids have been to the ophthalmologist or optometrist. They're like, well, it's normal for age. Okay, So I'm here to say that there is no normal for age in our population. Children with additional disabilities, with low vision, with CVI, should not be in these typical developing child guidelines. This is the guideline here. It was a consensus opinion with only a 68% response, and it was in children who were typically developing. So they would say, for example, up to a +6 under 1 year of age is okay. Now, for typically developing child, if you want to watch them a few months and wait, I think that might be okay. If you have a child who is not typically developing, you could be really penalizing them by not putting them in glasses early enough. So, and I get so many reports when I'm doing my outreach for school for the blind where the report says, glass is not indicated typical for age. And I'm like, I want the numbers. Give me the numbers and let me make that decision. You can't make a cutoff. Remember, every child's unique and you can't make a cutoff based on a chart of typically developing kids. Now, sometimes, we need to use bifocals in kids, and there's a whole way to prescribe these. The bifocal needs to be where the child can use it. And in cases where the child's eyes cross in the face of their adequate prescription, sometimes we use bifocals. We use glasses for anisometropia when there's a big difference between the two eyes, and we do that very early because that can lead to amblyopia or further loss of vision if not treated. But we have to do a good refraction. The child has to be dilated to do a good refraction. So one of the things you parents or teachers can say, did they get eye drops? If they didn't get eye drops, a small child did not have an adequate refraction. This is a little baby in Nigeria, and he has microcephaly, thought to be severely visually impaired. You can see I have this little test object. It's a happy birthday. We found he was very farsighted, hyperopic. I had these glasses with me. We put the glasses on him and he started seeing right away. So, so simple. Glasses helped him see. Dynamic retinoscopy is another art that most ophthalmologists and optometrists unfortunately don't use. I have much more success teaching it in other countries where what we do is when the child has their prescription on that is their normal prescription, we see, if they're focusing. It's very simple. You can take an object, hold it here. I have this instrument right here. I look at the child's red reflex. I get with motion. You can see there's a little with motion. And as I bring the object closer, the lens of the eye focuses and it turns to minus. It goes the opposite way. And you can see that and you can measure. You don't even have to measure it. You can just see the child do that. When the child does that, you know that they're accommodating. You know that the lens is changing shape. You know that you have attention. If that doesn't happen, then that child may need additional prescription in their glasses, or a child who is normal for age, doesn't need glasses, may need those glasses because they're not focusing. They cannot focus because of neurological reasons, very common in CVI, very common in kids with Down syndrome, common in some of our medicines for seizure disorders. So again, something that unfortunately is not evaluated enough. In fact, this is the only paper that's been written about it, and I was one of the co-authors when we had this epidemic in Brazil with congenital Zika and all of these kids with CVI. We tried to measure what we could and measure the effect of our interventions so that we could help not only those kids, but other kids with CVI. So this was one of the things this was one of the papers I think I'm proudest about, that we actually measured the effect of putting children in glasses. So what we did is we dilated the child, we did the refraction, the child came back, we had their glasses, we provided them at no charge. We put the glasses on the child and we re-measured their responses, all of the leg gradings, visual field, contrast, all of this. And we actually, in these kids, because we knew or we had a feeling because of their severe visual impairment that they were not going to accommodate, we gave them +3 over. Now, this was a technique I learned from Dr. Leah, and the +3 is for the communication distance of 30 centimeters or about a foot. So all of these children had over plus glasses. So it wasn't 100%, but 62% had immediate improvement in their visual function. And I give this paper to my families. I say, you know, other doctors may argue this isn't indicated, they don't know, whatever reason, but, and it's not 100%. Nothing's 100%, but we had 62%, and that's a lot. 62% is a lot. Just think if they wouldn't have had that opportunity. And we had 7 kids in our study. We had 60 children who had had no visual response without the glasses. And with the glasses, they had at least a visual response. Now, again, we measured it at the same time. So this is, we just did another paper in Brazil, and unfortunately it hasn't been accepted for publication to, again, this was another group of researchers who found the same thing. So, so I want to emphasize that all children need a good dilated or cycloplegic refraction with appropriate prescription of glasses. Now, glasses aren't going to work for every child. So I'm not saying, oh yeah, you have to have glasses for every child. I'm just saying, you know, you need to, with your doctor, say, okay, is this going to be appropriate for my child? Does it have the potential to improve their visual functioning? So I also carry a trial set with me. This little boy, when another child in one of my outreach clinics for Kansas School for the Blind, and his mom, I said, well, what are your goals for your child? What would you like your child to be able to do? And she said, look me in the eyes. I measured his prescription. I actually had it. I gave overplus glasses, and this is what happened. You know, he's a little boy, nonverbal with cerebral palsy, so motorically couldn't really show her. But once he got the glasses on, man, direct eye contact, and that was really powerful for us and for this mom. Glasses also need to be properly fit. I hear so many times, oh, my child doesn't like their glasses. No child likes their glasses. Most adults don't like their glasses. I'm always amazed in my office. Where are your glasses? Oh, I don't feel like wearing them today. You know, I can see big enough thing, you know, so there's a lot of people just don't like their glasses. And I don't know any child, maybe a handful, that would get up in the morning and say, where are my glasses? I want to wear them. Most child, it's one more thing on their face. It's one more, you know, if you have a child who has other things that they need to do, like a G-tube or suctioning or, you know, a cochlear implant, you know, with, I mean, hearing aids, all these things. Yeah, kids don't like them. They don't like hats. They don't like their shoes. They don't like their clothes or their diapers, you know, but we teach them how to wear those, right? So you can teach a child how to wear the glasses. I like a real positive approach. Start with supervised time where, you know, the caregivers with the child, keeping their hands busy, loving on them so they can't pull them off. Positioning is also really important. If your child's, you know, has to lay on their back or is in a wheelchair, you know, there's different ways to make the glasses so they're comfortably fitting. You can see this little girl here. Why do you think she didn't like to wear her glasses? Well, it smashes her eyes shut. You know, of course she's not going to want to wear them. This little girl, on the other hand, had well-fitting glasses with the little pink glasses here and is very happy with them. And this little boy, you can see this earpiece coming around his ear is really uncomfortable. So if we fit that properly, it's going to be comfortable for him. Sometimes a child grows very quickly and the glasses can actually smash them on the temples and then they get uncomfortable. So there could be a problem with fit. They might not be made with the proper prescription. Often that'll happen, too often actually, and the child can't say, hey, my prescription doesn't seem right. They're just going to pull the glasses off. So remember to get the prescription rechecked and to be sure that they're fitting properly. And there's other uses, other reasons in kids with low vision that we use glasses. We could just be using it for magnification for low vision. Sometimes there's a blinder effect that you can use for a child, you know, where you can get a darker, thicker frame, and that may help them if there's a lot of environmental distraction. This works in some kids with ADHD. Again, these are just ideas. None of these are 100%. What is 100% is all kids with low vision or who are monocular, only have vision one eye, should wear glasses full time. That's a medical legal issue. They should have polycarbonate protective lenses so that they don't either injure their seeing eye or, especially when they get in the preschool classroom or elementary school, things can start flying in a classroom, and a child with low vision may not see it, can't duck, or may run into something. So remember about protection for your kids with low vision. Transition lenses or tints for photophobia, depending on, some kids with CVI need this, kids with ocular albinism, kids who've had cataract surgery. And the main thing is glasses should be absolutely individualized, like any other intervention we do for our kids. This little eyeglass book is, I wrote with the New Mexico School for the Blind and Visually Impaired, and it's available. It's a free download. It's in English and Spanish, and you can print it off or you can take bits and pieces out of it. It goes through some basic terms on what's anisometropia, what's hyperopia, and it has some pictures and it talks about glasses. But the other thing about glasses is I think the team and the family really need to understand what the glasses are for. Often we'll get, feedback that, well, my child sees without glasses. Well, yeah, but are they getting the best image? Or are they ignoring one eye? So they're going to lose vision in one eye, but yeah, they can see out the other eye, but you've lost that opportunity to treat the amblyopia. So I think just proper understanding, and again, ask your ophthalmologist or optometrist exactly what are these glasses for. Are they to enhance near vision? Are they to enhance distance vision? Are they to straighten the eyes? In a child who has eye turning from high hyperopia or farsightedness, the eyes can turn. You put the glasses on, they're straight. The child can see without the glasses, but the glasses are to help straighten the eyes. So what are the glasses for? A real important question for families and teachers and eye care providers to understand. And does the family and educational team understand when the glasses are to be worn? Example, if it's to treat amblyopia, they need to be on all the time or the child's going to lose vision in the eye. If they're to help with up close, then you don't want the child to wear them when they're walking or trying to walk. So it's really important that we communicate that to you, or be sure and ask, when should the child wear them? And what's the expected outcome? Are they going to help visual skills? Are they going to help eye turning? Are they going to help communication skills? At what distance? How do we assess this outcome? That's always a hard question. There's not that many great outcome studies out there. We also understand that there are family quality of life issues. A lot of families, it's like, I don't want one more thing that my child has to put on in the morning. So I think it's really important for us to be sensitive to that and address that and emphasize the importance and try and make it as easy for families as we can. I think one thing that in our world, in Salina, Kansas, that's been made easy is in our Birth to 3 program, we provide the eyeglasses free of charge. We have a scholarship fund. We have a whole set of different frames. We fit the frames to each child's face. One of our teachers does, who's been doing this for a while. She's learned how to do it. I write the prescription. We send out for the glasses. They come back. They're brought to the child's home by the teacher or primary coach to be sure they fit. And then we're able to continue to support the family in that way. Most state insurances, Medicare, Medicaid provide glasses for children, but sometimes it's really hard to get a good fit. So we just took that in our hands to do that. And it's worked really well. We're also able to get the glasses that way wholesale at really a fraction of what it would cost a family who maybe has a type of insurance that doesn't pay for glasses. And so then the glasses, boy, you're going to go spend $200 on a pair of glasses that your baby's going to throw off their face. So that was one approach we did, and it's worked really, really well. In fact, in India, there was a big problem, and we're setting up manufacturing for babies' glasses at Aravind Oral Lab, which is in South India. It's just now in progress. They partnered with one of the eyeglass folks, and will now have proper fitting inexpensive eyeglasses for babies in India. So the other thing a lot of parents ask me is, how can I get rid of the glasses? When can my child get rid of glasses? When can they have refractive surgery? And refractive surgery is definitely something that is going to be in children. And there's been several studies, and there's several providers who actually do refractive surgery for children who have severe developmental disabilities and can't wear contact lenses or glasses. So there's just a few centers who do this, but it is going to become more of an option where, you have a child who just can't wear their glasses. Contact lenses are actually fit in children who are aphakic or have had surgery for congenital cataracts as early as, right after their surgery. Babies under 1 can wear contact lenses. It takes a lot on the parent or caregiver's part to put those contacts in, but contact lenses are another option. And sometimes we fit contacts in children, again, if they can't wear glasses, and it's a real specific group of children who could wear those. And also, what about bifocals? Bifocals, if the child doesn't know to look through their bifocal like an adult does. So you really have to have a proper fitting bifocal, and the bifocals typically need to come up halfway up the glasses so the child, when they look down, can use them properly. So understanding what the bifocals are for, is it for eye turning? Is it for low vision? And how the child is to use them is also really important. So I think sometimes we don't explain this properly. It's just like, here's prescription for the glasses, see you later, and so these might give you all some questions to go armed with to your ophthalmologist or optometrist office and ask these questions. So I wanted to give you some tools. So as far as, during the pandemic, it's been a tough time for everyone. We did virtual birth to 3, many of the kids I had seen. So I was looking at function, and we are able to, on a Zoom call or FaceTime, look at some of these components of the functional eye exam, like alignment. It's actually really nice. I can do a screenshot, and it helps me look at the light reflexes off of the child's eye to see if their eyes are aligned. We can look at visual fields, like in this little boy, his mom, this is a little boy with CVI, and I said, well, he's doing a lot better in down gaze now, and we're really excited about that. But I asked Mom to just roll the ball around so I could watch his response to the ball rolling around. Why that went so fast. And we can look at the functional assessment in a natural environment, which is really nice, with the child's reaching, if they're, what's their head position. This little girl, for example, is one I saw on telehealth, and the mom and the team were very concerned about her head turn. Well, I was able to just on the Zoom diagnose that she had nystagmus, and this was a compensatory head turn for her. So I was able to say, hey, when she needs a complete exam as soon as we can, but it's okay for her to look in that direction. She's compensating. That's actually a good thing. That means she's using her vision. There's a lot we can't do, of course, on telehealth, like we can't do a cycloplegic dilated refraction like I want to do. We can't look at the optic nerve or retina, although there is more and more actually photography that's going to be able to be done at home, and that can give us some of this information in the future. So, but there's a lot we can do. And I find the best reason for me to do the telehealth is to support parents and the intervention team. And we've been doing a weekly telehealth exam with Coimbatore, India, where they send me videos in advance. And then we have the pediatric ophthalmologist who's already seen the child there, along with her intervention team. We're actually mentoring an optometrist, several early interventionists in our country and also in Haiti. And we're all able to get on the Zoom, talk with the parents, go through the examination, the intervention strategies. And so we're all continuing to learn. And then we're able to give feedback right away to the parents too. So we're using it in this way, again, to support the parents during this time where travel is so difficult, and also to support the intervention team by helping to answer questions that can help the family and the child. So anyway, that's it. And I'm happy to answer any questions. And it's kind of a quick go through. Mainly, I wanted to emphasize the assessment that we can do that may not always be done, but it can be, and arm you with some proper, questions so that when you go in with your child or with your student to the ophthalmologist or the optometrist, that you can say, hey, can you do dynamic retinoscopy and see if they're accommodating and see whether they need those glasses. So I hope that gave you some insight. Thank you.
Thank you so much, Dr. Lawrence. It's so wonderful to see you and to hear you speak. And just, I'm so grateful for what you do for all of our kids globally with CVI and who have low vision. It's incredible. I just really appreciate you.